a lot of hospitals and news stations like to discuss the largest baby ever born in a hospital anywhere, and then they show this beautiful footage of this absolutely adorable, chunky little baby who looks so healthy and happy. And my first thought is always, I wonder what the mother's blood sugar average was during the pregnancy. Hello and welcome to Tala Talks NICU, where we take medical concepts and simplify them so that you learn them and hopefully retain them forever. So you asked and now we're delivering. This entire video is on Infant of Diabetic Mothers. So before you watch on, remember to like and to subscribe and let us know below what you would like to watch next. So like I said, today we're going to be talking about Infants of Diabetic Mothers, or as you know, we love our 3-letter acronyms in the NICU. That's also shortened to IDMs. So the topics that we're going to be going over today are 1, general information about diabetes during pregnancy, 2, the difference between gestational and pre-gestational diabetes on the babies, 3, congenital malformations in IDMs, 4, the way diabetes affects the infant's weight and size, 5, the size of the infant and the effect on perinatal trauma and depression, 6, metabolic disorders in IDMs, 7, hematological issues in IDMs, and 8, cardiorespiratory issues in IDMs. So stick around and you will learn everything you need to know. So let's start with some general information about diabetes during pregnancy. About 1 to 2% of all pregnant women will have either type 1 or type 2 diabetes, and a further 6 to 9% of pregnant women are diagnosed with gestational diabetes during the pregnancy. So as many of you have pointed out, this is really an extremely common occurrence for all babies, especially for the babies in the NICU. There are different ways that the OBs test mothers to see whether they have gestational diabetes or not, but generally the tests are performed somewhere between 24 and 28 weeks. And the first test that's done is generally, which is pretty much done on everybody, is an oral glucose challenge test where the mother is given like a 50-gram syrupy drink to drink, and then her blood sugar is tested an hour later. If it's above 140, then she is at increased risk of diabetes and she has to do another test. Then the mothers come back and have to drink this 100 grams of glucose, which is an incredibly very sickly syrupy drink, and then their blood sugars are tested 1, 2, and 3 hours after they've drunk the drink. And if 2 of those results are abnormal, then the mothers are diagnosed with gestational diabetes. Again, note that they are being diagnosed between 24 and 28 weeks. As you all know, or as you will learn, infants of diabetic mothers are at increased risk of many different abnormalities and disorders. But the good news is that the better that the mother's sugars are under control, the less likely that the infants will suffer from those disorders. So really good glucose control is really important for the mothers. Apart from measuring mothers' fasting blood sugars or just general blood sugars during pregnancy to kind of have an idea of how well her blood sugar is under control, the other test that can be followed is the HbA1c in the mother's blood. HbA1c is a measure of glycated hemoglobin, and it kind of measures the average amount of blood sugar that the mother experienced over the last 3 to 4 months. Ideally, in pregnant mothers with diabetes, that number is somewhere between 6 and 6.5%. Less than that, and that would be considered normal. So, for example, you can use this clinically. So, for example, you have a mother that comes in and she's about to deliver and her admission blood sugar is 95. And you know that she's diabetic, but you still feel that, okay, the baby's probably going to kind of be okay. And then you find out that her HbA1c is like 9.5%. At that point, you have to assume that actually her blood sugars have been pretty out of control and you need to be more concerned about the baby after it's born. So number 2, what is the difference between pre-gestational and gestational diabetes? Obviously, this is pretty straightforward. Pre-gestational diabetes means that the mother was diagnosed as having elevated sugars before she got pregnant, whereas gestational diabetes, like we already said, is normally diagnosed somewhere between 24 and 28 weeks. Different classifications have been put forward for how we should name mothers that had diabetes before pregnancy and also how long they've had it for. One of the earliest classifications for diabetes during pregnancy was developed by Dr. Priscilla White in 1949, and it's called the White's classification. And the White's classification is a list of letters starting from A, going further and further down the alphabet. And the further down the alphabet the letters go, then the longer the mother's had the disease and the higher the chance that the mother has vascular disease. Dr. White developed this to kind of estimate what are the chances that this was going to affect the baby. So logically, the further down the alphabet or the worse the diabetes is, then the higher the chance there is of vascular disease. And so the higher the likelihood that the placenta is going to have vascular disease as well, and that the baby would be affected and therefore have increased risk of preterm labor and stillbirths and everything else. Under that classification, gestational diabetes is A. If it's A1, it means that the mother does indeed have high sugars, but it's being controlled by diet. If it's A2, then it means that the mother is being given medications for her gestational diabetes. So again, A means that the mother was diagnosed with diabetes between 24 to 28 weeks. If the mother was diagnosed with diabetes after the age of 20 and has had diabetes for less than 10 years, then she's classified as a type B diabetic. You can look at the chart. I'm not going to go through all of these, but basically, as I said, the lower down the alphabet the letters go, the worse the diabetes is. So for example, type F means that the mother's now got nephropathy. If she's diagnosed with type R diabetes, then this is pretty much the worst. And at that point, she's got malignant retinopathy. So really bad vascular disease. I'm going to emphasize this point again. One of the biggest differences between gestational and pre-gestational diabetes is that gestational diabetes doesn't really get out of control until about 24 to 28 weeks. Why is this so important? This is so important because, as you all know, all of the organs are formed during the first trimester. And having high circulating levels of sugar, so if that developing embryo is exposed to high levels of sugar continuously, then the organs are much more likely to develop abnormally. That's what embryopathic means. In fact, infants born to mothers with pre-gestational diabetes, so diabetes diagnosed before they got pregnant, are 8 times more likely to have infants born with congenital malformations as opposed to infants born to non-diabetic mothers. Mothers with gestational diabetes have a slightly increased risk of having congenital malformations in their infants, but nowhere near the 8 times that pre-gestational diabetics do. And in fact, a lot of people postulate that that slightly increased risk is probably really just mothers that really were pre-gestational diabetic, but weren't actually diagnosed until the 24th to the 28th week of gestation. So again, just to emphasize one more time, the reason why true gestational diabetics don't have an increased risk of abnormal malformations is that it really doesn't kick in until way after the organs have already been formed. Organs are formed in the first trimester. True gestational diabetes doesn't really kick in until the end of the second, beginning of the third trimester. There is some very good news about pre-gestational diabetic mothers, and that is that numerous studies have shown that if mothers that have diabetes have really good sugar control even before that they get pregnant, especially before they get pregnant, then the chance of them having an infant with malformation absolutely plummets to really very close to the general population. So excellent sugar control in diabetic women who are trying to get pregnant is super, super important for the health of their babies. Number 3, let's go over some of the major congenital malformations that infants of mothers with pre-gestational diabetes are increased risk of having. So A, neurological abnormalities, and that includes an increased risk of neural tube defects, also called spina bifida. And that is where there is like an abnormally made spinal cord, whether the spinal cord and its coverings are kind of open to the outside world, so a baby is born and you can literally see the spinal cord, or where there is a tract going towards the dura or the meninges or whatever, or whether it's a tethered cord. Anencephaly can also occur more commonly, and that's really where large areas of the brain are just not formed properly. Babies that are also at increased risk of having hydrocephalus or more fluid on the brain, a lot of that is associated with the neural tube defects. And a really, really bizarre malformation that infants of diabetic mothers are also predisposed to is something called caudal regression syndrome. And that's really where the whole lower half of the body, kind of from the lower spine downwards, can be formed extremely abnormally. And their legs and the whole pelvic area can be really almost non-existent in these infants. Another big set of malformations that can occur is cardiac malformations. So in fact, these can be common enough that a lot of OBs would want to get a fetal echo on these mothers just to make sure that their heart is developing normally. But common heart defects include truncus, a transposition of the great arteries, or a TGA. Remember that one, TGA in LGA babies, that's a big exam question. Tricuspid atresias, also infants of diabetic mothers are at increased risk of having situs inversus, where just like all the organs are shifted to the other side, as well as just smaller malformations like VSDs and ASDs, but altogether much higher risk of having cardiac issues. And C, the third big category, is gut anomalies. And so really probably the most common here is atresias, especially anal atresias. The other kind of fairly common occurrence that happens in the gut is something called small left colon syndrome. And really this is where kind of the descending colon is just much, much skinnier than it should be in infants of diabetic mothers. So for example, say you have a baby that hasn't stooled in a day or a day and a half, then look back and check to see if the mother was diabetic or not, because if she really was a poorly controlled diabetic, then that could kind of guide you in one direction. Number 4, now let's discuss the way that diabetes affects the baby's size and weight. I'm sure that you all know this, but infants of mothers with both gestational as well as pre-gestational diabetes are much more likely to be macrosomic, or just really large, or what we call medically large for gestational age, which means that for whatever age they were born at, they are larger than 90% of the other babies. So they're above the 90th percentile. As an aside here, a lot of hospitals and news stations like to discuss the largest baby ever born in a hospital anywhere, and then they show this beautiful footage of this absolutely adorable, chunky little baby who looks so healthy and happy. And my first thought is always, I wonder what the mother's blood sugar average was during the pregnancy, what her HbA1c was, because I bet that in just about every single one of these babies, the mother probably had some level of diabetes. Many factors are implicated in why these babies get so large. One of them is insulin growth factor. And what's interesting is that these babies get really large bodies. So their trunk and their legs and their arms, their length and their weight is generally really large, but it doesn't seem to affect their brain and head growth as much. So normally the head circumference is a normal size, even in a baby that's LGA. And I'll explain why this is so important in a bit. The other important thing that you need to understand about weight in these infants of diabetic mothers is even though the vast majority of them are at increased risk of being macrosomic or large, there is a smaller percentage that is actually at increased risk of being small for gestational age. And going back to the White's classification system, those are generally the babies of mothers who have advanced and pretty uncontrolled diabetes. So according to the White's classification system, that is for mothers with type D diabetes onwards. So the ones that you'd expect to have pretty bad vascular disease, and so you would expect that to also affect the vascularity of the placenta. So these babies are at increased risk of being IUGR and ending up being SGA, even though the vast majority of babies before that, so A, B, and C, are much more likely to be large for gestational age. Now, number 5, let's talk about the effect that the size of the infant has on the actual delivery course. Now, it's pretty easy to imagine that if you're trying to deliver a really, really big baby, then that baby is much more likely to get stuck, especially if the baby is being delivered vaginally. What makes that even worse in infants of diabetic mothers is, like we already said, the head circumference is normally a pretty proportionate size. So it's not necessarily much larger like the rest of the body is. So what can happen is that the head can come out. It's not so massive that it can't come out. So the head comes out, and then the shoulders and the rest of the body get stuck because it's so much larger. And this is what's called shoulder dystocia. Obviously, this puts the babies at much increased risk of perinatal depression as well as of traumas. So logically, these babies would be at increased risk of having a brachial plexy injury, so like an Erb's paralysis or a Klumpke's paralysis. Also that increased risk of having fractures. So for example, a clavicular fracture or a fracture of the humerus. But the thing that we really worry about is the infant suffering from perinatal asphyxia or hypoxia or ischemia, where the baby, while it's being delivered, where if the head is stuck and the cord is stuck, the baby is literally not getting enough blood to its brain. And these babies can have severe perinatal depression and suffer from hypoxic ischemic injuries. So because of all these reasons, if the mother is known to be carrying a macrosomic infant, so an infant that is large for gestational age, then that mother is much more likely to be induced earlier at, say, 37 weeks or taken for C-section. So in fact, infants of diabetic mothers are at increased risk of having C-section, and by the way, all the other issues that can be more associated with a C-section, most notably TTN or transient tachypnea of the newborn. Number 6, let's talk about metabolic disorders in IDMs. And the one that everybody knows and automatically thinks about is the infants getting hypoglycemia. And let me just explain why this happens. If a mother has high circulating blood sugar in her bloodstream, then that high blood sugar will cross through the placenta and go into the baby's bloodstream through a process called diffusion, or facilitated diffusion if you're doing your neo boards, which, as you all know, is movement of a substance from a higher to a lower concentration. So all that sugar will just kind of carry on going through to the baby. The mother may have a high insulin level, but insulin does not cross through the placenta. So when the baby's body sees that high sugar, then the baby's pancreas will start making more and more insulin. This is completely appropriate during the pregnancy itself, when the fetus's body is actually seeing this high sugar, and we need the insulin to take this sugar away and put it into the cells. So what happens after the baby is born? The infant's pancreas is really revved up and producing a lot of insulin because the infant has been exposed to this high sugar concentration throughout pregnancy. So the pancreas is still really ramped up, but now that the baby is delivered, it's cut off from that constant source of glucose. And now the baby is responsible for itself to get glucose into the bloodstream. And most likely, the baby won't be able to get that same sort of substrate, won't be able to get enough sugar into the bloodstream as had been given to the baby during pregnancy. And the job of insulin is to take that blood glucose out of the blood and kind of pull it into cells and build up the glycogen and the fat stores and everything. And so the combination of the higher insulin and not having the same amount of glucose being given means the amount of blood sugar in the blood vessels of the baby is going to go down a lot. Couple that to the fact that a lot of these babies are large for gestational age and anyway need more sugar than the average for gestational age baby, then it's kind of like a double whammy for why these babies are going to end up with low sugars. They're LGA and they've got high insulin levels. The risk is such that really all infant of diabetic mothers should be screened for low sugars after birth, and whether that's for 12 hours or 24 hours, depending on your hospital's protocol, these sugars should be followed pretty carefully. If the sugar is somewhere below 40 to 45 mg per deciliter, then an intervention is probably needed. Again, I'm going to go over a whole other video on hypoglycemia, but for now, realize that IDMs are definitely an increased risk of hypoglycemia. And in fact, even though they are at increased risk of many other things that I'm also going to talk about today, the low sugar is the only thing that they actually have to be tested for. So all IDMs should have a sugar check at some point. One more thing that can contribute to low sugars in IDMs is potential feeding issues in infants of diabetic mothers. And nobody really knows why, but IDMs, especially the really large ones, can have the potential to have very poor coordination and strength and stamina for their feeds. So here we're talking about even late preterm and term babies. They can take a lot of time, even after they get over their hypoglycemia issues, just kind of learning how to feed their full feeds. In fact, they may be in the hospital for several days or several weeks just trying to learn how to feed. Again, nobody knows exactly why. Maybe it was related to the fact that they got the sugars so easily during pregnancy. Maybe it's something to do with just neurological latent development or something. But a lot of these babies can take a lot longer than expected just learning how to feed their full feeds. Infants are at increased risk for other metabolic disorders, for example, hypocalcemia or a low calcium, which is generally considered a serum calcium level below about 7. This is important to remember if you have like a really jittery infant and who is an IDM and you check the sugar and the sugar is like 70 and you're like, well, it's not hypoglycemia. Remember, it could be hypocalcemia. The low calcium is thought to be secondary to the interruption of the parathyroid hormone pathway, and normally it is transient. But if it seems to be affecting the babies anyway, especially if they're jittery, then the baby may need to have treatment, whether it's actually giving extra calcium or even giving vitamin D and stuff so that the calcium is better absorbed for the future. IDMs can also have hypomagnesemia, I said it, or a low magnesium level. And honestly, this is thought to be because the mothers of diabetic mothers generally do have a lower magnesium level, maybe because they urinate it out more. Again, this is transient as well, and unless it's a cardiac patient where you really want to have that magnesium and calcium exactly where you want it to make sure that you're not making the heart any more unstable, generally babies that have kind of slightly low magnesium are going to be asymptomatic. It is important for you to realize it though, because if you do have low calcium and you also have low magnesium, the calcium will not get corrected unless you also correct the magnesium. So if you ever have hypocalcemia in an IDM, also check the magnesium level. Number 7, hematological issues in IDMs. IDMs are much more likely to have polycythemia or a high hematocrit. So polycythemia is defined as a hematocrit above 65%. This is thought to be secondary to some level of placental insufficiency. So basically, these babies are really, really large, but their placentas aren't as proportionately large. So they're kind of being exposed to a constant level of a little bit of hypoxia. This relative chronic hypoxia will increase the erythropoietin level in the babies and therefore cause a higher hematocrit. Most of the time, this really isn't an issue. The babies are just nice and ruddy. But as that hematocrit gets higher and higher, especially as it gets closer to about 70, it can make the blood really, really sticky and end up with something called hyperviscosity syndrome. This can result in sludging or like the little clots or thromboses happening in the different blood vessels. So depending where this happens the most, you're going to end up with different signs and symptoms. So these babies are at increased risk of having a stroke. They are increased risk of having respiratory distress if more of that sludging is happening in the capillaries of the lungs. Or these babies are also at increased risk of having a renal vein thrombosis. So an IDM is at greatly increased risk of having renal vein thrombosis compared to the general population. Just to emphasize though, again, unless the baby is having some symptoms, then we don't really routinely check the hematocrit in these babies. Logically, if a baby has a high hematocrit, then they are at also increased risk of having jaundice or hyperbilirubinemia as that hematocrit slowly kind of breaks down and releases the bilirubin. In fact, for reasons not entirely known, even IDMs that don't have a really high hematocrit have a slightly increased risk of having jaundice. Most babies in the US at least are checked for jaundice at some point anyway, so this is pretty much a routine test checked in both IDMs as well as in non-IDMs. Now 8, cardiorespiratory issues in IDMs. Like we already said, in infants of mothers with pre-gestational diabetes, are at increased risk of having structural anomalies of the heart, for example, a TGA or transposition of the great arteries. So it is recommended that these infants, especially the ones with the mothers with the poorly controlled sugars, should get a fetal echo even obviously before the mothers deliver, just to check the anatomy of the heart. But even in infants of mothers with gestational diabetes are at an increased risk of the high sugars affecting their hearts. And the way that it can do that is causing a type of cardiomyopathy. It is always transient, but sometimes the infant and the heart has to be supported until the heart kind of remodels itself and goes back to normal. This type of cardiomyopathy happens when the interventricular septum, so basically the wall between the left ventricle and the right ventricle, gets really hypertrophied or muscular or much more thickened. If that intraventricular wall is really thickened, so say this is my LV wall and this is the intraventricular wall, then during systole, when the whole heart is being squeezed, it may get to a point that it actually blocks off the blood from going out of the aorta because the whole heart is much thicker than it should be. And so you end up with like an outflow tract obstruction because the blood literally cannot get out from the aorta because it's being pushed together. The muscles of the opposite side of the wall are being pushed together. This can result with decreased blood going to the body, as well as just kind of backup and respiratory distress. So sometimes we do have to treat this very aggressively. And the way that we treat it is kind of twofold. The first thing that we have to do is try to make sure it's one of kind of the rare diseases of the heart where we really want to keep the fluid level up because we want there to be lots of blood in the heart so that that left ventricle is full and it's less likely to become obstructed when it's squeezing together during systole. The second thing that we want to do, which we often don't do as well in heart disease, is we want to give a beta blocker, or we want to slow down the rate of the heart beating. Because if we do that, then there'll be more time in diastole where the blood can fill the left ventricle. And so again, with more blood in the ventricle, they're less likely to squeeze together and cause that outlet obstruction. Often we don't have to do anything. We may hear a little murmur and we'll get an echo and see that that intraventricular wall is slightly thickened, but really the baby is doing fine. Eventually, even in the ones that are really symptomatic, eventually the heart just kind of remodels itself and the heart will end up being completely functionally as well as structurally normal, whether that takes a few months or a few years. Finally, and this shouldn't really be finally, because honestly I think it's one of the things that we see the most after the hypoglycemia, is that IDMs are at increased risk of RDS, or respiratory distress syndrome, or surfactant deficiency. This is thought to be secondary to high levels of sugar, maybe delaying the production of surfactant in the babies. And practically though, what that means is that we may see worsened RDS in the smaller babies, but even in like a 37-weeker or maybe even a 38-weeker who's technically term, these are the babies that may present like they've got RDS and you can't really figure out why they've got their air bronchograms and their chest x-rays are hazy, and then you just kind of put it together that the mother had like really bad uncontrolled diabetes. And so these babies, even though they are term, are actually lacking surfactant. And then the other thing that we see a lot in IDMs is an increased risk of TTN, or transient tachypnea of the newborn, which you will know if you saw the TTN video. And really that is kind of twofold as well. The high sugar is somehow thought to delay the fluid absorption from the lungs, but also, like we said earlier, if the babies are large for gestational age, they're much more likely to be taken for an elective C-section, which means that they're much more likely to have TTN anyway. So definitely TTN is a much higher risk in IDMs. Okay, that was a lot today. I tried not to go too much into detail and I left a lot of stuff out, so I hope that it was helpful for you. Please do like the video and remember to subscribe if you haven't already. Thank you if you have, and please let us know below what you'd like us to talk about next. Thank you so much for being here.